could you give me a 8-minute shout? Okay. Yeah. Thank you very much. Yeah, my name is Matt Southwell. I'm a member of the International Network of People Who Use Drugs, and I'm the INPUD's representative on the NGO delegation. Actually, on this project, I was working as a consultant for HIT, which is a harm reduction and social marketing agency based in the UK. This project was a joint project between UNAIDS and the World Health Organization. But we're very pleased that other partners have then subsequently joined us in the project, including UNODC and the Open Society Foundation, which is particularly helping us with the translations of this document to ensure that we have it in a number of iterations in different languages to actually help with the rollout. So where does this guidelines first come from? There was an original, reasonably substantial document written by the World Health Organization that was a TB advocacy guide, but very much a sort of high-level policy document, really helping people look at what is the process of advocacy around tuberculosis, what are the key issues. The challenge was that that many of the sort of grassroots activists, people living with HIV, people who use drugs or people who inject drugs, weren't actually skilled up in in tuberculosis, and it wasn't strongly on the agenda of many drug user organisations. And I acknowledge myself as I came into this as someone who's been a drug user for 25 years, as someone who's been a drug user activist for many years and campaigned around a large number of issues around my community's needs, that this was a learning experience for me around tuberculosis, and I think it was a learning experience for many of the drug user activists within the process. So what we were trying to do was to take this established document and to translate it, as one of our colleagues said, let's translate it from UN into English, so that we actually can use it on the ground. And the idea then is to give people a very practical, tangible resource that particularly people who are already drug user activists and people who are living with HIV activists then can be paired up to use their existing advocacy skills to increase their advocacy agenda to press for issues around tuberculosis. So this was the key that we were working on. The methodology that we tried to use in this, I think, was really interesting, and I think it's a very good example of meaningful participation. I'll be one of the people who's jumped up and down about the need for meaningful participation, and it's really nice to come here and present a really good example of that process. There were a series of regional meetings facilitated with regional drug user networks like the Asian Network of People Who Use Drugs, and also global consultation facilitated by INPUD, and which drew together a very, very senior range of drug user activists from a wide range of countries, so China, Afghanistan, Russia, Ukraine, India, a number of European countries, Australia, the US, Canada. So there's a real breadth of engagement here. This was really frontline activists coming together to discuss this process. And what took place was a very nice skill sharing process, and it highlighted that it wasn't a passive process where drug users were sitting there saying, oh, it's very nice for the UN to teach us about tuberculosis, and we all go away saying, okay, well now we're much more knowledgeable about tuberculosis. What actually happened was a very dynamic exchange. The World Health Organization and UNAIDS came with this real technical knowledge about the global policy, about tuberculosis, about what needed to change in terms of a structural level and a policy and practice level. And then drug user activists came along saying, look, we know how to intervene in these systems. Now, we may be talking to some of the people we're trying to change about other issues. So we can talk to you about the methodologies we might use to actually bring about change. And I think at the end of some of these, at the INPUD meeting particularly that took place in Liverpool, people really walked away really saying, actually, this has been a very, very educative process for the two groups that came to the meeting, the UN officials and also the drug user activists. And I think that was one of the big learning points from a process level that really came out of the work. In the guidelines are reasonably simply set out. I'm sorry, they are literally with the printers as we speak, but we can send out an electronic version to people after this meeting. And it's a reasonably simple format because we want to easily translatable into as many languages as possible. So it's low on design, but strong on content and strong and accessible content. One of the examples we use in the program is best practice example in Afghanistan. And I think it's very interesting to take one of the, probably ground zero of the war on drugs in the world, and an incredibly challenging environment to do work in. But actually here we found a best practice example of how to work in an integrated way around people who use drugs. So as I talk about the structure, I'm just going to give some illustrations from that situation about what might be going on. So to start with, we really talked about some of these core advocacy issues were, and what were we trying to advocate about. So the first thing was about stigma and discrimination. And we've talked about this very widely, that stigma and discrimination clearly is a huge barrier to engagement in treatment. Now, when we're in Afghanistan, when we're working on the streets with people who are routinely beaten by the police, routinely having money stolen from them by the police, very difficult to move them from that space into a place where they're thinking about testing and getting involved in a sustained treatment regime, when life is really, really fundamentally about survival. And the other issue then also linked to stigma and discrimination is the issue of criminalisation. So, for example, what's recently happened in Kabul is there's been a process of dispersing the drug-using population successively over a number of years, from initially one site where they were all living to then living under bridges, to now being dispersed, scattered across the whole of the city, and largely due to police violence. Now, the challenge of that then means it's incredibly difficult to engage those people in services, for outreach workers to even find them, to begin that journey of drawing people into understanding TB prevention and engaging in treatment. So you can see how, as advocacy tries to take us in one direction, criminalisation can take us in quite the opposite. Fundamental in a positive nature was the positive effect of harm reduction. And what was notable about the population that were really well engaged in the midst of this, it was the pilot program on methadone in Kabul, where the first 70 people in Kabul in Afghanistan had access to methadone. And that gave them the chance to stabilise their lives, and it gave them the chance for services to interact with them on a regular daily basis, because as they came to pick up their methadone each day, that created a platform for delivery of ARV treatment and also tuberculosis treatment. Without that stability of opiate substitution therapy in their lives, the range of other healthcare interventions became impossible. And it was a really noticeable the difference of engaging the population on LST and the population who remained highly criminalised and marginalised, living on the streets, just desperately trying to survive from day to day. The thought of long-term dying from TB becomes very difficult to hold on to when you're trying to survive till tomorrow. And then another key area was then also access to ART, and I think this idea of this combined process where we saw in this OST clinic in Kabul, ARVs, methadone, and TB treatment all being dispensed at the same time each day, so that actually adherence became in people's lives who were very unstable. And this population was the most problematic population of drug users out of an incredibly problematic population, so this was not an easy group to work with. But it was amazing that methadone provided this stability. It allowed a platform to interact with this group of people and help them have that treatment adherence. And interestingly, just to reference in the US, there's a very good example in the US where actually drug users started to buddy with each other to help each other remain compliant with TB treatment. And what was really interesting about the program was it showed that if you put two drug users together to try to remind each other about their TB treatment, it often broke down, because you could almost get into collusion around not taking your treatment. But when you had three people, person A reminded person B reminded person C, and person C reminded person A, the model worked very, very nicely. And drug users themselves, in their daily lives, their daily interactions, were the people reminding each other to take their TB treatment and to think about what they needed to do. The other core thing which I think the Kabul model highlights is the need for service integration. Now, when drug users are running around every day trying to struggle to get money to have enough money to stop yourself going into acute withdrawals, you don't have time to go to 4 or 5 different services to pick up your different levels of intervention. And Annette has really highlighted how people are now having this whole series of co-infections, and we need to think about how do we allow people to easily interact with all of those services rather than saying this is how we want to run our services and you now just need to run around the city for the whole of your life doing nothing else but engaging in healthcare. Significantly, we didn't do a lot of work on this, but we're really acknowledging that prisons are increasingly an incubator for tuberculosis among people who use drugs. Now, putting large numbers of people who use drugs in overcrowded prisons becomes a very, very effective way of spreading tuberculosis through that population. And we really need to think about that as another aspect. Is this it? Time? Yeah. As another aspect of criminalisation. And then, in fact, I'm nearly finished. But then the other area that we wanted to highlight was the issue of employing drug users in services. One of the things we as drug users would argue is that the fact that when we work in services, it doesn't have to mean that we're the only staff in services, but when we have a presence in services, we have a very powerful sensitising effect on that service, because we can help people understand what our lives are like. And so, where stigma and discrimination is reflected through employment laws, that even in my own country we have to be 2 years drug-free to actually work in services, our expertise then is left out of the service, but also our sensitising effect to the service is left out. So that's the sort of general range of advocacy issues that we were trying to target. The guide goes into far more detail. It talks people through clear advocacy strategies. We talk about a range of different levels of advocacy, and we give people very practical guidance about what they can do in each of those different areas. I'm very pleased to say that we will have this in Arabic, in Chinese, in Russian, in English, in French, and other languages that we're still working on. And our hope now is that it becomes a key vehicle to power up advocacy among people who use drugs and people who are living with HIV to fight for effective TB treatment as part of a comprehensive package of care for people who take drugs. Thank you very much.